Hi everyone, it's Dr. Catherine Pomerola from IVFMD South Miami. Thanks for joining me for the March first week on fertility, where we'll be talking about ovarian aging. So this is many questions patients bring about their ovaries, their ovarian reserve, the number of oocytes, the quality of oocytes, so hoping to address as many questions as possible. So first, talking a little bit about how we test for ovarian reserve. So we actually have many methods to look at egg numbers. This would include the antral follicle count, counting the very small follicles within the ovary at the beginning of your period. This gives us an idea of egg numbers and can fluctuate slightly month to month, but usually we don't see drastic changes in antral follicle counts between month to month. So again, that's performed with an ultrasound, looking at the ovaries, counting the small follicles on each ovary, ideally at the beginning of the month, day 2 to 3. We also have the anti-Mullerian hormone or AMH. Sometimes this is also called Mullerian inhibiting substance. This is a hormone that gives us a reflection of egg counts. It's produced by the very small follicles within the ovary. So the higher the AMH, this reflects on higher egg numbers. The lower the AMH, lower egg numbers, again, because it's secreted by the small antral follicles within the ovary. We can test this level at any time of the month. It does not fluctuate drastically within the menstrual cycle. However, birth control pills, especially combined birth control pills, can artificially lower this number. So if you're on birth control pills and you had an AMH checked and it was low, often it's recommended to repeat this either 3 to 6 months after stopping the birth control pill to give a more accurate reading. Finally, we often check hormone levels at the beginning of the period. This is the FSH, or follicle stimulating hormone, LH, luteinizing hormone, and estradiol levels at the second or third day of your period. And this gives us a reflection of how the ovary is functioning. I covered this a little bit in my last month's first week on fertility, but when these levels start to change, it is a reflection that the function of the ovary is starting to decline. So not much it doesn't give us a precise indication of egg numbers, but rather how the ovary is functioning in conjunction with the brain, the hypothalamus, and the pituitary. So again, these are 3 measures of rough egg counts or egg quantity. Unfortunately, we do not have a test at this time for egg quality, which is critical to the success of fertility treatments and pregnancy. Egg quality is an assumption that we make based on women's age. So studying hundreds of thousands of women across the US, across the world, looking at their age and their risk of miscarriage, we're able to infer egg quality. It is thought that the aging process of the ovaries does start around age 35, so increased risk of miscarriage starting at age 35. And this picks up pace at age 40 is what I tell my patients. So there has been research done on the exact risk of aneuploidy, meaning abnormal chromosomes following fertility treatments by age. And this process starts around 35 and increases systematically and then drastically after the age of 40. So this is how we make judgments about egg quality, primarily based on age. Of course, every woman is different. The aging process within each woman is individualized, but we are able to have generalized conclusions or generalized assumptions based on a woman's age. Now, that age aside, it is thought that in women whose egg quantity is declining before it should, or premature ovarian insufficiency, it is also thought that the quality of those eggs declines in conjunction with quantity. So as a woman is nearing the end of her reproductive lifespan, whether it be at a normal age or whether it's premature, it is thought that the egg quality declines with that quantity. So what is diminished ovarian reserve, or DOR, as we commonly refer to it in the fertility world? This is a reduced number of oocytes or egg quantity by age. Certainly, at our practice at IVFMD, we have standardized curves based on expected AMH levels, and we're able to compare a woman's AMH value to our standardized curve. Many labs have similar standardized curves of expected values for the AMH by age. So if a woman's AMH comes back significantly lower than we would expect for her age, this would be concerning for a lower ovarian reserve than expected. And certainly any woman's AMH below 1, I do get concerned about lower ovarian reserve or lower egg counts. The exact cause of what causes the lower ovarian reserve in many patients can be unknown. Certainly we can expect this level to decline with age, but when we see a lower count in certain women, sometimes the exact etiology or cause remains unknown. There are some proposed mechanisms to explain what is causing ovarian reserve to decrease, both prematurely in some women as well as in the natural aging process. Some of these proposed mechanisms include a decline in the mitochondrial function. Mitochondria are like the powerhouses within the cell. They produce energy for the cell, and of course the egg requires a lot of energy in order to be able to produce an embryo, divide appropriately, separate the chromosomes. This is very energy consuming. So certainly if there was a decline in the mitochondrial function, this may explain the aging process, the lower quality of those eggs. Another proposed mechanism is telomere shortening. So telomeres are small portions at the end of chromosomes, which contain our genetic material. And the telomeres are responsible for protecting the structure of that chromosome during normal cell divisions. Before a cell divides, it has to go through a combination of, it has to combine its chromosomes, line them up, divide them appropriately, and any abnormality in this process can result in an abnormal embryo. So telomeres are responsible for keeping that chromosome intact, preventing any sort of breakages or abnormal divisions of the chromosomes. As anyone ages, the telomeres in all of our cells start to shorten. So one proposed mechanism of ovarian aging is that these telomeres within the oocyte or the eggs start to decline as well. Another proposed mechanism is that for ovarian aging is abnormal chiasmata or cohesins or meiotic spindles. So these are all very scientific words for how the oocyte lines up its chromosomes and divides. Again, the major concern with lower quality eggs as women age is abnormal embryos. And this is the major contributor to miscarriage. So if there's any abnormality in the meiotic spindle, which is responsible for lining up those chromosomes and helping them to divide appropriately, this can result in diminished ovarian reserve, diminished oocyte quality. And then finally, as women age, there can be an accumulation of DNA damage and reduced ability of the cell to repair that DNA damage, resulting in abnormal chromosome divisions, abnormal DNA, and hence abnormal embryos. So all of these are possible proposed mechanisms. I always find the scientific background behind why things are happening fascinating. A lot of research is still to be done to better understand why this is happening so that we can improve our treatments and improve outcomes for patients. But that aside, when should you be concerned if this is happening too early? So premature ovarian insufficiency, or previously known as premature ovarian failure, is when menopause occurs before age 40. So we actually only know menopause in retrospect. It's about a year after the last period. So if this happens before age 40, this is considered premature. Certainly women who are found to have very reduced ovarian reserve, extremely low AMHs, very low antral-follicle counts before the age of 40, but they're still getting periods, we are concerned about their risk of developing premature ovarian insufficiency. Some testing that may be performed to determine why you're going through premature ovarian insufficiency would be certain genetic testing to see if you're a carrier of Fragile X, karyotype testing to see if you have Turner syndrome or a Turner's mosaic, certain immune testing, certain autoimmune conditions make you more prone to premature ovarian insufficiency. However, in about 50% of causes, we don't have an exact reason for the premature ovarian insufficiency. But this would be of a concern with very reduced diminished ovarian reserve before the age of 40. We have some iatrogenic causes, meaning induced causes of reduced ovarian reserve. This would be chemotherapy or radiation. Anyone who's been exposed to these gonadotoxic or harmful to the ovary medications and treatments for cancers in the past. Even if you haven't had cancer, certain medical conditions like rheumatoid arthritis, lupus, or sickle cell disease require very harmful or very helpful therapies for their disease, however, harmful for the ovaries in terms of reducing egg counts. Especially the medication Cytoxan has been known to cause reduced ovarian reserve, sometimes early menopause in women. Any surgery that's performed on the ovary has the potential to reduce egg counts, even under the most skilled of hands, even under the hands of a fertility surgeon. Any surgery on the ovary has the potential to reduce the egg counts within that ovary, or certainly if an ovary has been removed because of a large cyst or concern for cancer, this would reduce a woman's egg count. Interestingly, the fallopian tubes do contribute part of the blood supply to the ovary. So women who've had one or both fallopian tubes removed sometimes see a reduced ovarian reserve because of this reduced blood supply. As we talked about briefly earlier, combined oral contraceptive pills, meaning pills that have both estrogen and progesterone components, can lower the AMH, but this is reversible. After stopping, you would expect to see the AMH return to a normal level, or that person's normal level within 3 to 6 months. Great. So what are our treatment options? What can we do about women who are concerned that they have lower ovarian reserve or lower egg quality? So if you are a patient who is anticipating needing chemotherapy or radiation or any other medication that is potentially going to harm the ovaries, we do have the ability to do egg freezing to preserve your ovarian reserve, preserve as many eggs as possible before undergoing this therapy, which may push you into menopause or close to menopause. So this is certainly an option, both egg banking as well as embryo banking. The difference being either freezing your eggs alone versus freezing eggs and sperm combined. However, many women are incidentally found to have ovarian reserve. They're not planning to undergo chemotherapy, but they may not be ready to have children at this time. So if you're incidentally found to have very low egg numbers, it may be a consideration to freeze your eggs to preserve that option of fertility in the future. The alternative sometimes is a recommendation to try for pregnancy right away. However, this may not be an option financially, socially, psychologically at that time. So for these women, egg or embryo banking is an option. Sometimes in order to get the optimal or desired number of eggs to ensure future fertility, multiple rounds of egg freezing may be needed. So now, in terms of what all of the supplements, all of the additional possible treatments for IVF that may improve egg count or propose to improve egg count, I'd like to spend the majority of the rest of our talk on these topics, as it's critical to our field. There's a lot of good information out there, but there's also some bad information out there. So first, why is it so difficult to do fertility treatments in women with reduced ovarian reserve and ovarian quality? Well, the basis of our fertility treatments is to improve egg number. We really don't have proven treatments to improve egg quality. So the majority of our treatments work on improving egg numbers. We can only work with the eggs that you have or the antral follicles that you have. We have not been able to develop new technology that will grow new eggs, unfortunately. Though there is some research trying to do exactly that. But a woman, again, is, once she is conceived, she has the most number of eggs while she's still inside her mother's womb. This peaks at 20 weeks gestation. So halfway through a pregnancy, you have the most eggs. And by the time you are born, you've already lost over half of these eggs. There's a continual decline in the egg numbers. By the time a woman enters menopause, it's thought that there's about 1,000 eggs or less, but many of these are not accessible by our treatments. So diminished ovarian reserve, lower egg quality poses difficulty to our fertility treatments because we have a very low starting point. Additionally, as women near menopause, the function of the ovary starts to decline. It's not responding to the hormones that the brain is releasing in a normal or predictable fashion. The communications between the oocyte and the ovary are breaking down, and so our treatments that we have at this time are mostly trying to overcome the normal system, the normal functioning of the brain and the ovary. But since the ovary has already started to decline in its function, it's very difficult to get the ovary to respond in a predictable manner. So these women who have lower ovarian reserve, lower egg quality, are certainly higher risk of cancellation of their cycle if they don't develop a follicle or don't develop multiple follicles in preparation for IVF. They may ovulate prematurely. We have very predictable timing of when ovulation occurs based on follicle sizes and hormone levels, but it is not uncommon to see women with lower ovarian reserve or lower egg quality ovulate unexpectedly, either before an insemination cycle or unfortunately before IVF cycles as well. Additionally, they are prone to abnormal fertilizations, meaning egg and sperm do not combine normally, and abnormal embryo development, poor quality of embryo arrest before the blastocyst stage, and even when tested genetically, found to be abnormal embryos. So there are also multiple limitations in our research abilities on women with diminished ovarian reserve. First of all, there's very variable definitions of who qualifies as a diminished ovarian reserve patient. There's multiple kind of standardized criteria for diagnosis of diminished ovarian reserve or poor ovarian responders. These would include the Bologna criteria or the Poseidon criteria, but the research that's been done across the world are using different criteria for diagnosing DOR, so this is a limitation in how to compare these studies and how to make the findings relevant to your patient population. However, there is ongoing work to try to standardize this definition so that research is more clear-cut and powerful in the future. Women who've had diminished ovarian reserve or lower egg quality, they've often gone through multiple IVF cycles. So the research on their poor response and the subsequent treatments has absolutely been influenced by their prior outcomes. So this makes the research a little bit more muddy and less clear-cut, whether it's kind of the additional treatments that were given in the subsequent cycle that were beneficial or whether it was just another cycle and better luck is sometimes hard to tease out. Often there is a regression to the mean, meaning it's possible that absolutely no changes were made in an IVF stimulation and we have a better outcome versus if a new treatment was added and we saw a better outcome. It's really difficult to say whether the benefit was seen from this new treatment versus just doing another cycle. So again, these are all limitations in our ability to research the treatments for diminished ovarian reserve and oocyte quality and limit the power of our findings. So, and then finally, there are many proposed benefits of supplements. However, supplements are called supplements and not medications because they are not FDA approved. And unfortunately, this results in variable levels of active ingredients in each of the supplements. So if you go to any pharmacy or any drugstore, you'll see a huge variety of supplements. They may have all varying amounts of the active compound, and they are also not regulated so they can provide advertisements, false advertisements regarding their efficacy. So these are all things that are limiting our ability to perform strong research on treatments for ovarian reserve. But that being said, let's dive into those, what is available at this time, the pros and cons, and whether there's a true benefit. So there is one very efficacious, very successful treatment for diminished ovarian reserve and lower egg quality, and this would be egg donation. Unfortunately for many women, many couples, this is not an option. This is a huge step psychologically, mentally, as well as financially. Egg donation involves borrowing eggs or using the eggs of egg donors, either anonymous egg donors or a known friend if they qualify for egg donation, but borrowing the eggs of a younger woman. So again, under the age of 35 are often in egg donors. These are women under the age of 32 or even 30, so assumed to be high quality, often high number of eggs to go through treatment, but it has obvious limitations. It does not contain the genetic material of the patient, and so there's that's a huge next step for many patients. So often we are considering alternative therapies to attempt to improve outcomes from IVF cycles or more natural methods through the use of supplements or additional additives to our normal fertility treatments. So first, I thought we should talk about some of the supplements. And actually, there was a very recent publication out of a journal called the Human Reproduction Update, which is a reputable journal, from February of this year, 2020. And they did a systematic review and meta-analysis of all of these adjuvant treatments for poor responders undergoing IVF specifically. They looked at CoQ10, DHEA, growth hormone, testosterone, and numerous other additives. And they did actually find a benefit of CoQ10, DHEA, and growth hormone in women who use these compared to controls in the setting of poor ovarian responders. So let's look into each of these. CoQ10, or also referred to as ubiquinone, this is an enzyme that is involved in cellular respiration, meaning making energy for the cell, or ATP. ATP is required for doing about 95% of a body's function, so critical. We actually find the highest levels in the organs that are most active, like our heart, our liver, our kidney, and not unexpectedly, the oocyte, having to do many energy-consuming activities during its division and creation of the embryo, also requires CoQ10. CoQ10 is also an oxidant, an antioxidant, and can reduce oxidative stress, or free radicals that can form as a result of normal activities or daily life exposure, environmental exposure, but free radicals are damaging, causing inflammation within the body. So CoQ10 acts to sweep up these free radicals, these oxidants, to reduce that type of oxidative damage. So CoQ10 has been shown to possibly improve oocyte quality or egg quality and improve outcomes from IVF treatments. This is supported by multiple small studies. However, there are also randomized controlled trials, and this recent systematic review and meta-analysis also demonstrated improvement in IVF outcomes from the use of CoQ10. Specifically, they found significantly higher pregnancy rates compared to controls who were not taking CoQ10 and lower cancellation rates compared to controls. So CoQ10 is something that I believe in. I take it myself. I encourage my patients with diminished ovarian reserve to take it. I don't necessarily think every patient needs to take CoQ10. It's certainly not harmful, but specifically for women with lower ovarian reserve and diminished egg, or thought to be diminished egg quality, so over the age of 40, potentially they may benefit from CoQ10. The dosage is important, so you'll see many different doses of CoQ10 in the pharmacy. I don't believe anything more than 400 to 600 is necessary per day. But however, I encourage you to speak to your fertility provider regarding their opinion as well. Okay, DHEA is the second one that this systematic review and meta-analysis found to be helpful. So what is DHEA? This is actually a precursor hormone that can be converted to both estrogen and testosterone. And it has been shown to have potential benefits to improve egg quality and embryo yield, as well as clinical pregnancy rates and live birth rates in older women, meaning over the age of 40, with poor ovarian reserve. So this has been supported by retrospective studies, which were slightly lower quality, or certainly lower quality than randomized control trials, but they also have found a benefit within small randomized control trials in this meta-analysis that was recently performed, specifically demonstrating higher clinical pregnancy rates versus control. Now, I don't recommend DHEA for certain medical conditions. For example, women with PCOS, they have endogenously high androgen levels. DHEA is a type of androgen. So if a woman has high androgen levels at baseline or has PCOS, this is not a good medication for them. And specifically, it's only been studied or been shown to have a true benefit in older women over the age of 40 with diminished ovarian reserve. So I do often reserve this for older patients who are going through IVF treatments and maybe have had a failed cycle in the past as an alternative method. Some other supplements to be considered is L-arginine. This is an amino acid which is required for making proteins or important substances within the body. It has been shown to benefit the cardiovascular system. So most of the research on L-arginine is from cardiac research, and it's thought to increase nitric acid or oxide production and improve the endothelial and vascular health, thereby improving peripheral circulation. So this can be translated to ovarian function. If you have improved ovarian perfusion, there is the potential to improve egg quality, egg quantity for the IVF cycle. Additionally, it also has been shown to improve insulin sensitivity and can stimulate the release of growth hormone, as well as act as an antioxidant. So while the research behind L-arginine is not as strong as CoQ10, there are these proven benefits within the cardiac literature, which can translate to ovarian health to potentially improve egg quality. Then finally, two more supplements to cover. The first is turmeric or curcumin. So curcumin is actually the biologically active compound within the root turmeric. This is actually from a flowering plant. It is related to the ginger family, and it's found to be native in India and Southeast Asia. It has this classic yellow-orange color, so often used in dyes or as a flavorant in Asian cuisines, especially curries. But it has been shown to have some anti-inflammatory and antioxidant properties. And there's many promising animal studies to show benefits within the ovary following artificial damage, as well as studies that have studied turmeric and curcumin as an adjuvant in cancer therapy, specifically ovarian cancer. So this has, again, there's no direct link to turmeric or curcumin in terms of improving egg quantity and quality. However, its antioxidant properties, anti-inflammatory properties may translate to improved ovarian function as well. Then finally, omega-3 fatty acids. So in general, this can be beneficial to many aspects of your health, but specifically for the ovaries, there's actually 3 types of fatty acids: alpha-linoleic acid or ALA, which is found from plant oils, as well as eicosapentaenoic acid, excuse my pronunciation, EPA, as well as docosahexaenoic acid or DHA, which you may commonly see in the pharmacy or drugstores. So these are actually derivatives of marine and animal oils. So the fish oils that you commonly are instructed to take or have been heard are beneficial to your health actually contain the EPA and the DHA compounds. These are thought to be important components of fat metabolism, and they're considered essential fatty acids because they are critical to the growth of young humans as well as young animals. And actually, we're not able to synthesize these within our body. We cannot make them. We have to derive these amino acids, or these essential fatty acids, from the diet. So there's multiple natural sources of these omega-3 fatty acids, or you can consume them in a pill form. In terms of the evidence behind the health benefits of omega-3 fatty acids, there was a 2013 systematic review that showed tentative evidence that omega-3 fatty acids can lower inflammation, and specifically the blood markers of C-reactive protein, which is a very important inflammatory factor, interleukin-6, as well as tumor necrosis factor alpha. So by lowering these factors, omega-3 fatty acids contributes to anti-inflammation, reducing inflammatory damage within the entire body, as well as translating to reduced inflammation within the ovary. There's also some evidence to support that fish oils can lower blood pressure levels and improve circulation, reduce triglycerides, which all may translate into improved ovarian perfusion, improved ovarian function, reduced inflammation. But again, there's no direct strong correlation between fatty acids and ovarian reserve testing. So moving on to some of the commonly added adjunctive therapies for IVF. Some of these were addressed in the Human Reproduction Update, so we'll cover those at this time. So one is considered testosterone, often given in the form of a testosterone patch. It's thought to influence recruitment of follicles at the pre-antral and antral stages. So again, the antral follicle is what we can see on ultrasound at the beginning of your period. Pre-antral are follicles before this stage. And actually, the majority of our IVF medications only act on the antral follicles. It is still a kind of a black box how to activate the follicles before that stage. But this is where there's a larger pool of eggs, and if we are able to master recruitment of these follicles, this would be a huge improvement in our IVF therapies. So there is some potential evidence that testosterone may stimulate these pre-antral follicles, and will act synergistically with follicle stimulating hormone, which comes naturally from the brain or from our medications, in the early follicle maturation. It can also promote granulosa cell proliferation, which are the cells, critical cells within the egg, helping to support its growth, releasing estrogen levels, and it may enhance the anti-Müllerian hormone protein expression within these granulosa cells. So potentially, testosterone may improve or increase the number of recruitable follicles or recruitable eggs in women with diminished ovarian reserve. However, the mechanism of action, how it exactly does this, the dose that is required to optimally recruit these follicles, and the duration of therapy that's needed is still very much unknown. Some stimulation cycles use this in conjunction with the gonadotropins during stimulation. Some providers start this treatment several weeks in advance of the IVF cycle. There's still a lot of research that needs to be done to kind of optimize the outcomes of testosterone therapy. The Human Reproduction Update that I keep referencing, this very recent systematic review, did demonstrate a higher number of usable embryos following testosterone use. And there is actually an ongoing trial right now, ongoing randomized control trial, which is one of our strongest forms of research, that is looking into the use of testosterone patches in IVF. So hopefully we have some good outcomes following that trial. But it does show some promising benefits in older women with diminished ovarian reserve. The second one that I'd like to cover is growth hormone. So growth hormone is involved in the regulation of early follicle development, as well as egg maturation, or the maturity of the eggs, meaning how many can be successfully combined with sperm. It does this through both direct effects as well as through other factors within the ovary. It has been shown to increase the sensitivity to gonadotropins, or the medications we use in IVF, and improve the function of mitochondria within the ovary. It's found to have increased levels of estrogen during a stimulation cycle that involves growth hormone, require lower doses of the gonadotropins or lower IVF medications, and yield a higher number of eggs, higher number of transferable embryos. So again, growth hormone was found to be successful from this recent systematic review and meta-analysis. They demonstrated through the use of growth hormone in IVF cycles an increased number of eggs that were retrieved compared to controls. On average, this was 1.7 more eggs compared to controls. So we're not talking drastic increases, but it was statistically significant, as well as a higher number of transferable or usable embryos. So again, this has been shown to be promising. I have been using growth hormone in my patients, very specific selection of patients. However, the research has been shown in older women, again, over the age of 40, and or women with concerns for diminished ovarian reserve. So it may not be appropriate for everyone. Another important caveat to remember is that this is an adjunctive therapy. We don't have long-term research from the long-term effects of this therapy on the babies born through IVF with this medication. So we are finding normal embryos. However, long-term impacts on the babies in their childhood and their adulthood is still to be determined, and will be difficult to obtain that information given the lower numbers of cycles that use growth hormone. All right, so now moving on to some very alternative therapies, groundbreaking research that is really not mainstream, but hopefully as we learn more about these therapies may play an important role in the treatment of diminished ovarian reserve. So there has been some research done on mitochondrial enhancement or mitochondrial transplant. So again, the mitochondria are the powerhouses of the cell. They create and provide energy for most cellular functions within the body, and they are critical to the function of the egg. Ovarian aging has been correlated with a decline in mitochondrial function, and there has been shown to be an accumulation of mitochondrial DNA damage as women age. So mitochondria are also critical to the formation of the meiotic spindle and how the chromosomes line up and then separate. So any abnormalities in mitochondrial function translates into abnormal embryo development because these chromosomes can't separate appropriately. This is a very energy consuming process. Strong mitochondria, lots of energy production is critical to preventing an aneuploidy or abnormal chromosome division. So therefore, we've developed the possibility of mitochondrial transfer. Certainly this is not mainstream. This is still a research protocol. Very limited number of centers do this procedure. And again, it's under a research protocol. But we are able to transfer mitochondria from a healthy donor, an egg donor, in essence, is able to donate the mitochondria from their healthy eggs into an embryo that was created using eggs of a woman of diminished ovarian reserve. We can do this through cytoplasmic transfer, meaning the cytoplasm, the insides of the egg that do not contain genetic material, is able to be transferred between a healthy egg and the embryo of a couple with a diminished ovarian reserve. This is also possible through meiotic spindle transfer, meaning taking the genetic material of the couple with concern for diminished ovarian reserve, removing that genetic material and inserting it into the egg of a egg donor that had its genetic material removed. So that's called meiotic spindle transfer. Very exciting research, very promising, but still very much in the research phase. Actually, at Columbia, we had the opportunity to do some research with couples who were going through mitochondrial transplant, not so much for diminished ovarian reserve, but for mitochondrial diseases. It is very promising findings, but still very much in its infancy, not ready for mainstream at this time. However, if you are interested in mitochondrial transplant, I would encourage you to seek out one of these centers that is doing this on a research protocol. Additional possible therapies promoting or advertising that they are promoting improved ovarian function, quality, as well as number, is platelet-rich plasma. So platelets and platelet-rich plasma contain cytokines, chemokines, coagulation factors, integrins, lots of growth factors that may promote cell division, proliferation, differentiation, all sorts of important cell functions. And the theory is that injection of this platelet-rich plasma, or PRP, directly into the ovaries will somehow activate the eggs that have been dormant and allow them to be recruited and stimulated to improve egg numbers and egg quality. So that is very much the theory. There are very limited information, lots of minimal information on the success of this. One study performed direct injections into both ovaries of 19 women with diminished ovarian reserve, and they did result in 3 pregnancies, 2 of which were natural, 2 of which were natural, 1 of which was following IVF. But research and proven outcomes using PRP direct injections into the ovary are still very, very limited. This is an alternative therapy, probably should only be performed under research protocol at specific centers, but it is, I'm aware that this is out there and some centers are performing this, but the evidence really is not there yet. There is some true science behind it in terms of the theory, but we still have a lot to learn before we can introduce platelet-rich plasma routinely into practice. Similarly, along the same lines, some centers are injecting stem cells into the ovaries. So there are small reports of recovery of ovarian function and even fertility after hematopoietic stem cell transplant into the ovaries. But again, these are very small studies, often done under research protocols at very specific centers, and really a lot more information is needed before we can determine that this is efficacious as well as safe for our patients. But these are kind of hopefully coming down the pipeline as we gain more information about these different alternative therapies. Then finally, if we are able to generate eggs or oocytes from stem cells, this would be a drastic improvement, a game changer in IVF for women with diminished ovarian reserve and poor egg quality. So we have been able to generate sperm cells from stem cells, adult stem cells, and certain areas of the world, specifically China and Japan, they are very close to generating oocytes from adult-derived stem cells, but still this is very much undergoing research. Much more information is needed. Long-term outcomes of the safety of these are still needed before it's possible to offer this to patients. But very exciting research in the field, and hopefully some improved treatments for our patient with lower ovarian reserve. So finally, wanted to address some of the questions that came in. Thank you so much for piping in advance. I had many patients ask questions, so I'll kind of jump right into them. One listener said, I'm 38 and I had a failed cycle with a PGS normal embryo. Is 38 too old for IVF with your own eggs? And I would say absolutely not. Certainly we are concerned about the quality and quantity of eggs after the age of 35. This picks up pace after 40, but you're in this critical period where adjustments can be made. The fact that you did have a PGS normal embryo or pre-implantation genetically tested normal embryo is a great sign. Unfortunately, it's not a guarantee to result in pregnancy. There are still cases where pregnancy does not occur or miscarriage occurs in the setting of a normal embryo. But the fact that you were able to generate a normal embryo is a great sign. Your doctor may be able to adjust certain things in your protocol to attempt to make more PGS normal embryos with the next cycle. But I would say after one failed cycle, this is too early to give up. I think there is hope for you. Another listener said, I'm 31 and I've had my first failed cycle, also with a PGS normal embryo. I'm getting ready for a second cycle with growth hormone. Does growth hormone really help? So we did just speak a lot about growth hormone. So this listener is 31. the research behind growth hormone has truly been in older women, 40 or above, with diminished ovarian reserve. If you are 31 and have extremely low ovarian reserve, it's possible this may be considered as an alternative therapy, but the research and the evidence is really behind the older women in terms of improving their cycle outcomes. The fact that you generated a PGS normal embryo is also a great sign, so I do think that there is hope. I would be cautious about the just arbitrary use of growth hormone. It really should be used for a very specific patient population, but of course your provider knows your case best, and certainly I'm sure has reasons for the introduction of growth hormone at your age. Another listener asked if underlying diseases can affect ovarian aging. And absolutely. So unfortunately, endometriosis is a very common condition that can affect ovarian reserve. And it's kind of multifactorial in how it does that. First of all, women with endometriosis are likely to undergo surgery, potentially surgery on their ovaries to remove endometriomas or other cysts, potentially other pelvic surgery that can affect the blood supply to the ovary, as well as even if there has been no surgery on the ovary, women with endometriosis are thought to have a reduced ovarian egg count compared to their peers due to the nature of the disease process and the inflammation that occurs. Additionally, there are multiple autoimmune conditions that have also been shown to have lower ovarian reserve and certainly put these patients at risk of premature ovarian insufficiency. So women with autoimmune conditions may also develop antibodies to their ovaries, which can impact the ovarian reserve function. So there's multiple autoimmune conditions, specifically thyroid conditions. Any type of autoimmune condition may have the potential to impact ovarian function as well if there's ovary antibodies involved. Any sort of inflammatory condition, in general inflammation like lupus or rheumatoid arthritis or other systemic diseases that result in high amounts of inflammation may certainly impact ovarian reserve. We're learning more and more about the role of inflammation in many health conditions, but specifically within the ovary, it is thought to have a critical role. And certainly states of increased inflammation can impair the normal function of the ovary and potentially may certainly harm the quality of those eggs. And then finally, any sort of vascular condition, whether it's uncontrolled high blood pressure that's impacting blood vessel perfusion of the ovary, atherosclerosis and development of plaque, which can influence perfusion of the ovary, or certainly diabetic, extremely uncontrolled diabetic conditions that impact the blood vessels and supply of the ovary, also have the potential to impact ovary reserve. And in general, conditions that are poorly controlled, general health conditions absolutely would have an impact on ovarian health as well. Another listener asked, does obesity and BMI affect ovarian aging? So there's not really a direct evidence to show that women of higher body fat or higher obesity have lower egg counts compared to their peers. However, absolutely, they can be impacting the quality. And this is mostly through inflammation. So the accumulation of visceral body fat or the bad type of body fat, specifically within the central adipose region, this can generate very high levels of inflammation, inflammatory factors, which absolutely can impact egg quality. So while there's no direct evidence that obesity can reduce egg quantity, there is emerging evidence that this can absolutely impair the function, how the ovary signals and egg communicates within the ovary, as well as the quality of those eggs. So that brings me to the end of the questions that people sent in advance. Let me just see if any new ones popped up before closing out for today. Good. All right, I think that is about it. Thank you so much for joining me. And I look forward to our April first week on fertility. Feel free to send me topics that you'd like to discuss. Otherwise, I'll choose a topic of my own. All right, have a great night and hope to see you soon. Take care.